Hello all, I'm Dr. Shweta Santhalia, course director and founder of MRCOG. I'm teaching now since 3 years. I have 3 years of online experience of teaching and more than 10 batches I have done already. And the students are happy with the outcomes and the way we are handling them. So I'm happy to serve you today. Presently, I'm working in Barts NHS Trust, UK, London. So I'm aware of the practices happening here. So that will definitely help us in learning thromboprophylaxis in gynecology in a better way. I'm very happy that this talk has come in Jan 2023 talk regarding the thromboprophylaxis in gynecology because there was no literature for that for us to follow for exam, and the exam question of that would become very difficult for us. Now it will be easier, hopefully, after going through this talk. I would suggest you to go through another talk of anticoagulant in perioperative gynecology surgery, which is about direct oral anticoagulants in the YouTube recording of MRCOG, which is also quite commonly asked in the exam. So that will make this knowledge complete. I'm happy to announce our new course, which is a 5-month standard course, which has a free crash course with a minimal price, the right guidance at the right time. And this is the course features. And there is a group discount of 50% for a group of 2 or more. So what does this talk says? Mainly the thromboembolism, why it is important is it is a major cause of preventable morbidity and mortality. So because it is preventable, we should try and prevent it. Because thromboembolism is the second most common cause of death, according to MRCOG UK. That's why they always talk about thromboembolism. That's why the RCOG guideline of VTE is always important. The same way, the GTG VTE is important, and now for gynecology, this talk will become important. So they say that hospital-acquired thrombosis, which happens within 90 days of surgery, is for 50 to 60% of thromboembolic event are because of that. So hospital acquired is responsible for 50 to 60% of the events. So if we do the right risk assessment and we do the prophylaxis, we can avoid this chunk. That's why it is important. It's not only patient safety, but cost reduction for NHS as well. So it's important. We do have GTGs for ops patient, but there was paucity of guidance for gynec practice. So this talk will give us clarity about how to score a gynae patient before surgery and what to give, how to give, and how long to give. Why it is important in gynecology patient? Because they always have a multimorbidity, like they're old aged, they have multiple like diabetes or insulin, hypertension, and many more. So it's become important then that we do a right risk assessment for them. And gynecology surgery, the pelvic surgeries, pose a unique risk factor for thrombosis. So we have to take that into the consideration. If you see VTE, it is a major cause of morbidity, mortality, and its preventable complication. And if you don't give them thromboprophylaxis, the incidence is 17 to 40% for a major abdominal surgery, which is quite high, isn't it? For a major abdominal surgery like fibroid removal or myomectomy, hysterectomy, and big ovarian cystectomy, it will be 17 to 40% if you don't give them anything. So it's quite high. Following surgery, the risk exists for first 12 weeks. So they may ask you in SBA that how long the risk exists after the surgery. So it exists for first 12 weeks. And the likelihood of admission is in the first 6 weeks greatest. So they might ask you in SBA regarding the weeks, how long. So this you should keep in mind. What the NHS target? NHS target that 95% of the admitted inpatients should have VTE risk assessment. So this will help us in reducing the VTE in the surgical patient. As I told you, hospital acquired or hospital associated thrombosis HAT It is defined when the event occurred in the hospital or within 90 days of hospital admission. So any woman admitted in hospital, if she developed VTE within 90 days, that will be called HAT. And this is 50 to 60% of all thromboembolic events. This accounts for 57.1 VT related death per 100,000 admission. So this is significant. If you discuss about VT in early pregnancy, then the things come in our mind are hyperemesis and OHSS, isn't it? And in first trimester itself, the VT risk increase. That's why in GTG of VT, they have mentioned that if the score is more than equal to 4, you have to give them from first trimester itself. So if you see thrombin generation start increasing as early as 5 weeks itself. And if we talk about OHSS, we all know that with OHSS, severe OHSS, we have to give thromboprophylaxis for full first trimester because it's an atypical thrombosis happen in upper body. Arterial system are affected. Neurological symptom could be there. So atypical presentation. And it can happen even after OHSS is over, even after months. So at least full first trimester you have to give in severe OHSS. So the new information they have given in this talk is there is 100-fold increased risk of VTE in pregnancy, which happened with IVF and had OHSS, compared to 5-fold increased risk with IVF without OHSS. So compared to a normal pregnancy, in IVF pregnancy, 5-fold increase risk, and IVF with OHSS, it will be 100-fold increased risk, which quite a significant high risk. And they may ask you that in SV as well, how much fold increase? So 100-fold increase. So if they are pregnant, you are going to give them for full first trimester in severe OHSS. So what you are going to do if they are not pregnant with OHSS? If they are not pregnant, they say that thromboprophylaxis can be discontinued at the time of withdrawal bleed. This is a new information. If they are not pregnant, they are gynae, and then it will be at the time of withdrawal bleed, you will stop that. Then we all know about Virtue's triad, which is the pathophysiology of thrombosis, which is stasis, endothelial injury, and hypercoagulability of the body. Now, the risk with miscarriage, this is a new piece of information they have given that what to do with miscarriage and ectopic pregnancy, early pregnancy, right? So, in miscarriage, they say that paucity of evidence about the thromboprophylaxis with medical or surgical management. But in recent MRCOG in 2020, they have found a death because of ectopic pregnancy because she was more than 35 years of age. 35 years of age and other risk factors. She's undergoing salpingectomy, which is a surgery. So if you don't evaluate that properly, then she may develop thrombosis. So she came 7 days back with thrombosis. So they have come up with the new piece of information saying that any surgical procedure in pregnancy or puerperium should be assigned a score of 3 for any woman who is pregnant, right? So the ectopic pregnancy miscarriages also they are pregnant. So if you are doing surgical management of miscarriage or you are doing surgical management of ectopic pregnancy, then it's a surgery and then you should score it a 3 and then at least 10 days thromboprophylaxis you have to give them. So this is very important for your clinical practice also that you consider this and give them 10 days of prophylaxis. Then hyperemesis when they are admitted because they are hemoconcentrated, you should give them thromboprophylaxis at the time of admission in the hospital. So this is about the gynae. So risk factor for thrombosis is something patient related and something procedure related. So if you see patient related, it could be their personal factor like their age, their BMI, their ethnicity. They could be smoker, they could be contraception user, they could be pregnant, and there could be some morbidities like medical comorbidity, VTE history, thrombophilia, or cancer, or inflammatory intra-abdominal condition. So this will give them the patient-related risk, And procedure-related risk would be the time of surgery, the length of surgery, the length of anesthesia. Either it is done laparotomy or minimal invasive. How complex was the procedure? And how long she's going to be immobile after the surgery. If it is more than equal to 3 days immobility, it becomes a significantly reduced mobility. If it is more than 1 hour of surgery time, it becomes a significant surgery time. If it is laparotomy, the risk is higher compared to minimal invasive laparoscopy, hysteroscopy. So this we have to keep in mind. Then comes the risk related to underlying malignancy. We all are aware that many times in recalls they have asked us the question of malignancy. If you are operating for malignancy, how long you are going to give them the thromboprophylaxis? So it's 4 weeks post-operatively, we all remember. So they have elaborated it further, saying that in malignancy also, how much is the risk, what modality of surgery you are doing, accordingly, how much is the risk. These all important facts they have highlighted. So there is a higher risk of VTE if you do it through laparotomy compared to laparoscopy. We have discussed that. So with minimal invasive, if you see, the risk could be as low as 0.5%, but still you have to do the calculate the risk factor scoring, and accordingly you have to give them the prophylaxis. Then comes the complexity of the cases. If it is low complex, they have found no cases of VT. If it is intermediate complexity, they have found 0.5% cases. And for high complexity, they have found 2.8% cases. So let's see what are these complexity cases. Low complexity means simple diagnostic laparoscopy or second look laparoscopy. Intermediate complexity is all other benign gynec surgeries. And high complexity is the oncology surgery like radical hysterectomy, lymphadenectomy, splenectomy, or bowel colon resection. So these are the high complexity oncology, and simple diagnostic laparoscopy or second look laparoscopy is low complexity, and all other benign surgery will be the intermediate complexity. So please try to memorize these numbers. Sometimes in exam they ask you numbers, that how much is the chance and how much they found. So if there is underlying malignancy, as I told you, the risk is more with laparotomy compared to laparoscopy, but still you have to score it and accordingly give it. And if you give them dual prophylaxis, which is mechanical plus pharmacological, and you give them extended prophylaxis for 4 weeks, it will effectively reduce the VTE risk. If you see the cumulative incidence of DVT for epithelial ovarian cancer, it's 6.5%. So they may ask you this percentage as well. So try to memorize as much as you can. Definitely you can't memorize all the percentage, but keep an idea. Now risk with CHC. What do you think? Is CHC safe? Definitely CHC make it more hypercoagulable. That's why we are always talking about which progesterone lead to more hypercoagulable state and which progesterone is safer, because mainly it is because of progesterone. So they say that levonorgestrel is the safest progesterone. So second generation CHCs are safer in terms of DVT risk, and in third generation norgestimate is safer as levonorgestrel. So these are the two favored one in terms of DVT risk. So if you see outside the pregnancy, the risk is 1 to 5 per 10,000. And if they're using CHC, the risk becomes 3 to 15 per 10,000. So it's 3 times the risk when they're using CHC. And they say that it is highest in the first year of use and the first few months. So don't start, restart, restop like that. Frequent stopping, starting is discouraged. If you have started somebody on CHC, they should continue it as long as they want, rather than starting and then again stopping, thinking the risk of DVT. Because again and again stopping and starting further increase the risk. After 1 year, the risk reduces and stabilizes. So first year is the greatest risk. So before surgery, because the effect of thrombosis lasts up till 4 to 6 weeks after stopping CHC, they say that cessation is recommended at least 4 weeks before surgery. at least 4 weeks, because the risk is up till 4 to 6 weeks. So stop 4 weeks before elective surgery and restart at least 2 weeks after regaining full mobility. Now, regaining full mobility is a clinical judgment. If a woman is completely mobile, doing all their activity, then 2 weeks after that, you are going to restart. So be careful about that. Sometimes they will tell you that she is taking CHC, it's failure of CHC, she came pregnant, ectopic pregnancy, what to do? So that's fine. You can operate her. For elective surgery, you want to stop, but for emergency surgery, you can't do anything. But you will give it a score of 1. So if they are on CHC, they will get a score of 1 in evaluating the VTE risk. Sometimes you may give them the alternative progesterone only contraception compared to CHC. So that will help. HRT. What you're going to do? Are you going to stop HRT before surgery? The answer is no. No need of stopping HRT prior to surgery because it doesn't increase the risk of VT in perioperative women. Then HRT with DVT. There is a beautiful talk of 2015 which tells about HRT, which is safer, which is not, and things like that. You should go through that. But transdermal route is the safest, they say. While in CHC, they say that route doesn't matter. Either you give them uh, ring or patch or oral, it is all same. But in HRT, transdermal is the safest. Estradiol is safer compared to conjugated equine estrogen. And in UK, we are not using conjugated equine estrogen anymore. So estradiol is safer. Estradiol dihydrogesterone is the lowest risk. And if we compare estrogen only to estrogen plus progesterone, estrogen only is safer. So if a hysterectomized woman, you are going to give estrogen only, isn't it? So estrogen only is safer. So these are the risks associated with HRT in terms of VTE, which we should remember. But you can continue HRT in a perioperative period. But when you are evaluating the risk, it will get a score of 1. So it will get a score of 1 and CHC will also get a score of 1. Regarding the route of surgery, laparotomy is more risk compared to laparoscopy. So if you see laparoscopy, the risk is 0.13 to 0.2%, 0.1 to 0.2. While in laparotomy, it is 0.2 to 0.6. So quite high compared to laparoscopy. But as I told you, in laparoscopy also, you have to do the risk assessment and accordingly give them the prophylaxis. Even if it is for benign, laparotomy will be more risk for compared to laparoscopy. Then comes the vaginal versus abdominal. So vaginal surgery is very low rate of ET. So for prolapse, they have done a study on 63,108 patients, and they have found that vaginal route has the lowest incidence of ET, which is 0.16%, and then come the laparoscopy, which is 0.25%, and then come the abdominal, which is 0.72% in the 30-day post-operative period. So vaginal has the lowest risk. Then comes the urogynec surgery. If you do urogynec surgery, again, laparotomy will have more risk. If you're doing a POP repair or if you're doing concurrent incontinence procedure, mesh procedure, then they say the risk is similar. It doesn't add on the risk. If you do concurrent hysterectomy also, it doesn't add on the risk of VTE. So you can do it concurrent without the fear of extra risk of VTE for them. So vaginal is a good surgery modality in terms of VT reduction. Then comes the duration of hospital stay. We all know nowadays the daycare surgeries are increasing. We discharge them the same day. So anytime if you are discharging them within 24 hours, means in 23rd hour also if you are discharging, that become day surgery. So outpatient procedures are reducing the risk further and the risk is only 0.15%. So it's quite good. If you see, inpatient will have 70 times risk compared to outpatient within 1 day, daycare surgery will have 10-fold risk. So its inpatient will be further 7 times more. If you see numbers, 1 in 140 for inpatient, 1 in 815 for daycare surgery, and 1 in 6200 for women without surgery. And definitely the risk is highest for hip and knee replacement and cancer surgery. So does it mean that any patient coming for hysteroscopy and going within same day doesn't require a prophylaxis? It doesn't mean that actually. If it is a simple hysteroscopy like hysteroscopy polypectomy, they will tell you a young girl who came for hysteroscopy polypectomy, undergone uneventfully, and you have sent her home same day. So does she require thromboprophylaxis? She doesn't. But again, here you have to do the risk assessment, you have to do the scoring. If her BMI is more, if her age is more, if she has other risk factors, she might need. So hysteroscopy less than 60 minutes doesn't need. Hysteroscopy less than 60 minutes and no other risk factor doesn't need. So they will not tell you that it was less than 60 minutes. They will tell you uncomplicated hysteroscopy polypectomy. That means it will be just 15 to 30 minutes. So that you should understand. Uncomplicated hysteroscopy procedure will not take longer. Small polyps will not take longer. So this you should understand that they will not need a prophylaxis in such scenario. Then comes a mode of thromboprophylaxis, what you will give. There are several measures like either you can simply do ambulation, hydration, or it could be mechanical, or it could be pharmacological. So mechanical methods are mainly stockings, either it is TED stocking or graduated compression stockings. So these stocking basically avoid the venous venous blood retention, and it help in circulating the venous blood. So it will avoid the stasis. So stockings are going to work by compression, and the maximum pressure is at the level of ankle, which is 18 mm, and as it goes up, the pressure decreases. It should be a proper fit stockings, and they say that knee length stockings are more comfortable compared to the thigh length because patients feel more comfortable with knee length. Then in the study, they have seen that graduated compression stocking is also quite effective by this a low quality evidence. Then they have compared the intermittent pneumatic compression device alone or with combination, and they found that if they are using it in combination, the risk is lowest. So combination is always better. Whenever you are using stocking, you have to look for the contraindication, which could be either arterial disease, arterial bypass graft, peripheral neuropathy, or skin condition like dermatitis, where it's difficult for them to use stockings. Then comes the pharmacological thromboprophylaxis. In pharmacological thromboprophylaxis, they say that first choice is low molecular weight heparin in UK. Though effectivity of low molecular weight heparin and unfractionated heparin is similar, but still low molecular weight heparin is preferred because of its predictable pharmacokinetics, less complication, once daily dosing, and more cost effective. So low molecular weight heparin is the first choice. Have you ever heard of preoperative thromboprophylaxis? This is something new information and very fascinating to hear that preoperatively you should give thromboprophylaxis to avoid VTE. We always worried about preoperative thromboprophylaxis because then patient might bleed more during surgery. But they say that in major gynec surgery and gynec oncology procedure, if you give them preoperatively, start preoperatively and continue intraop and post-op, there is 40% reduction in the odds of VTE. So please keep this information in your mind. They may ask you an exam that somebody who is undergoing oncology surgery, she's preoperatively on heparin, what you're going to do. So you're not going to stop it, you will continue it. This is what they're trying to ask you. And they say that there is no significant increase in the risk of perioperative bleeding. So it might bleed little extra, but statistically that is not significant. So you don't have to worry about bleeding, but more about the thrombotic risk for her. They say, but however, they say that timing of optimal timing preoperatively is not established. So it's developing, but they have clearly mentioned that it reduced the risk of VTE. What about Fondaperix? Do we have to give anybody Fondaperix? So yes, sometime due to ethical consideration, because low molecular weight heparin come from porcine, it's a porcine derivative. Some women might refuse it on ethical ground, on their regional belief. What to do then? You can give them Fondaparinix. So Fondaparinix is a good agent for reduction of VT, but bleeding complications are more. The other problem is it is a longer duration of action and there is no reversal agent. That's why it is not the first choice, but yes, if you can't give low molecular weight heparin, you can give Fondaparinix. Then comes the direct oral anticoagulants. The direct oral anticoagulants, as I discussed about the other TOG recording in the YouTube channel of MRCOG about direct oral anticoagulants, it's a very important talk and it covers about apixaban, dabigatran, and rivaroxaban, when to stop, when to start before surgery, warfarin, when to stop, when to start. So that is perioperative anticoagulant basically. Just go through that recording as well. So these are the agent basically. It's a rapid onset of action, short acting, and low bleeding risk. So in gynecology, this rivaroxaban and dabigatran are not very commonly used, but they have compared apixaban with enoxaparin in a gynec oncology patients in an RCT in 2020, and they found that there is no statistically significant difference in terms of VTE or bleeding risk. It's similar, but patients feel more comfortable taking apixaban because this is oral tablet compared to enoxaparin, which is an injection. So keep this in mind that it doesn't make any difference, but still patients prefer apixaban. They might ask you that which is better. So you should know that both are similar. Apixaban and enoxaparin, both in oncology practice, they have found it's similar. Then they have given this new drug name, which can be used for the reversal of the new direct oral anticoagulant. Just try to memorize the name if you can. For apixaban, if you see, it is andixanet alpha. So just try to memorize that if you can. So these are the risk factor for bleeding to be considered whenever you are prescribing pharmacological thromboprophylaxis, because these are contraindication of pharmac thromboprophylaxis, low molecular weight heparin. If the platelet is less, if uncontrolled blood pressure, recent stroke, she's bleeding, she's having bleeding disorder, then you can't prescribe her the thromboprophylaxis. So if you see in a gynec surgery patient, this is the summary and this is a highlight of what we have discussed till now. If she has personal history underlying malignancy, you are definitely going to prescribe her the pharmacological thromboprophylaxis if there is no contraindication. If there is contraindication, then you have to rely on mechanical prophylaxis. If no contraindication, give them pharmacological. You will continue that for a specific period of time, like 4 weeks for oncology and 7 to 10 days in gynae surgery according to her score. If you have discontinued the CHC, you have to consider recommencing it 2 weeks after regaining the full mobility. You have to stop the CHC, but no need of stopping the HRT. This is a very important and very clear information. Please don't forget this because a simple thing to remember and do correct in exam. No number, nothing. That you have to stop CHC 4 weeks prior elective surgery and HRT, no need of stopping. Whenever you will assess the VTE risk, if they fall in high or highest category, you have to give them pharmacological thromboprophylaxis. If they fall in low or moderate category, you don't have to give them anticoagulation. Just simple ambulation either or mechanical prophylaxis while they are in hospital should be enough. So this is the most important chart for a scoring number as well as how long you are going to prescribe and what you're going to prescribe them. So if you see this risk score, if you see it's important in terms of their personal things like age, BMI, what they're using, what medical problem they have, mobility, and blood transfusion, immobility, smoking, cancer treatment, these all are important, as well as the duration of surgery. If it is less than 1 hour, the score is +1. More than 1 hour, the score become +2. It's very important. Now, if you see the scoring, what is the +5? Let us see the +5. So +5 is hip, pelvic, leg fracture, stroke, multiple trauma, spinal cord injury. So it's mainly for the major surgery, trauma surgery or fracture, hip, pelvis, orthopedic surgery, spinal cord surgery sort of things are not related to gynae. Gynec oncology will be coming in +2. So it's not related to gynae +5. Then comes the +3. Let's see what are the +3. So +3 are VTE history, personal history of VTE, family history of unprog VTE, high risk thrombophilias, which are 83 deficiency, protein C, protein S deficiency. So this will be +3. Then +3 is we have seen any surgery in pregnancy or puerperium will become +3. Then +3 is the age, more than 75 equal to or more than 75 years will become +3. Let's see what are +2 then. +2 again, one age lower, so 61 to 74 year is +2. BMI more than 40 is +2. Patient, if she is going to be bedridden for more than 3 days, it's +2. Active cancer treatment will be +2. Immobile plaster cast will be +2. Regarding the bed rest, they define it as inability to walk 10 meters at a time. Going to bathroom or walking in room are not considered ambulation. Please keep this in mind. We think if the patient is going to bathroom, walking in the room, it's ambulation, but it's not. Walking 10 meters at a time is ambulation. So please keep that in mind. This is very important for us to understand in our clinical practice what is actually ambulation means. Then comes the +1 score. So let us see +1. So if you see the age 41 to 60, usually the gynae patient will be in this range and oncology will be in this range. So +1, 41 to 60. BMI more than 30 or 30 will become +1. If they are using CHC or HRT, will become +1. Varicose vein +1. Pelvic mass of significant size. So what is significant size? Significant size is fibroid more than 12 weeks. Any mass significant to cause venous compression. For example, fibroid more than 12 week size. So that become significant pelvic mass. Then comes the currently on bed rest will be +1. Medical conditions will be +1. Major surgery in last month will be +1. Smoking +1. Blood transfusion +1. And less than 1 hour surgery +1. So this is very important. If 40 age, 0 score. If 41, 1 score. So if I give you just an example of surgery, a 42-year-old woman came to you with a fibroid of 14-week size, going for surgery. She's a smoker. She's using CHC for her contraception. And she came to you for surgery. You told her to stop CHC, but she didn't stop. The surgery went off a little longer because she bled quite a lot. So she had more than 60 minutes of surgery and she received one blood transfusion. So what's her score? So she got a score for her age, which is 42, a score for fibroid 14 week, which is pelvic mass of significant size, so 2. Then her surgery went off. She's a smoker, so score 1, 3. Then she had a blood transfusion, which became 4. And then the surgery went off for more than 1 hour, which became 2. So total 6. So she's falling in the range of 5 to 8, which is high risk, where you have to give her low molecular weight heparin for 7 to 10 days. Very important, right? And then let us take a cancer example, which might fall in a higher range. Cancer usually will be in this age group. So 61 to 74 will be +2. They are cancers +2, +4. The surgery definitely will be longer, so it will be +2, so it becomes 6. Pelvic mass definitely will be bigger, so that will become 7. Definitely they will be needing blood transfusions, so it becomes 8. And if they are going to be immobile more than 3 days, it becomes +2. So they become the score of 10. It's simple calculation. Their age, or if there is BMI, again it adds a score. Smoking adds a score. Immobility, definitely it is going to be there. Cancer is there. Her age is there. Surgery time is there. Blood transfusion is there. So they easily fit into the criteria of more than 9. Then you're going to give them 30 days of low molecular weight heparin, either alone or with the mechanical intermittent pneumatic compression device. So this is important. These two are very important category where you are going to give 7 to 10 days and where you are going to give her for 30 days is what you have to understand. If the score is 1 to 4, you just have to give them stockings, means mechanical prophylaxis during hospitalization. And if the score is 0, low risk, you don't have to do anything, just ambulation is enough. So this is what this chart summarizes beautifully about how to score and how to give them thromboprophylaxis. So that's all about this talk, and I expect that definitely you have gained some knowledge through this recording, and this will be helpful in your exam of July attempt, because it could be important for July attempt, because this is Jan talk, so definitely it can come in July. So this is our new course starting. If anybody wants to join, it's 5-month course with free crash course, and charges are minimal, which is £299. These are the course feature, and 50% off for group of 2 or more. Why us? Because we give small group teaching, personalized care, always available, and guide you in the right direction with right motivation. These are our group links. If you have any query, you can always message me or mail. Together we can succeed. Your success is our goal. So if you need right guidance at right time, we are here to help. Thank you. Thank you for your time.